Raynaud's phenomenon, when the patient exposed to cold or emotional stimuli, those may trigger vasospasm, leading to characteristic sequence change of color. First, causing digital pallor due to vasospasm. Second, cyanosis due to collection of deoxygenated blood. And then redness due to reactive hyperemia. Primary Raynaud's phenomena or cold disease, this affects 5 up to 10% of young female aging from 15 to 30 years in temperate climate and may be familial. It does not progress to ulceration or infarction with no significant pain. The underlying cause is unclear. No investigation is necessary, and the patient just needs psychological support and just to avoid exposure to cold. Sometimes long-acting nifedipine may be helpful. Secondary Raynaud's phenomenon or syndrome, this occurs in elderly patient in association with, first, connective tissue disease, mostly include CREST syndrome, which is known as limited cutaneous form of systemic sclerosis, and it is a multisystemic connective tissue disease. Refer to calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, telangiectasia. Second, vibration induced injury، وخاصة عند الناس اللي يشتغلون بالهمرات هاي العمال. Third, thoracic outlet obstruction due to cervical rib. Unlike primary disease, secondary type, it is often associated with fixed obstruction of digital arteries and causing fingertip ulceration, necrosis, and pain. The finger must be protected from cold exposure and trauma, and infection require antibiotic treatment, and surgery should be avoided if possible. Sometimes the patient needs sympathectomy that may help for a year or 2 years. Sometimes patient need prostacyclin infusion, and this may give some beneficial effect. Another subject is acute limb ischemia. بالمحاضرة السابقة تكلمنا عن الكرونيك limb ischemia. هنا نفس شيء بسيط عن الacute limb ischemia. هنا نتكلم عن السيمتوم and the sign of acute limb ischemia, including pale وpallor pain, and pulselessness, which means the pulse of the patient and may be absent in complete ischemia. بالcomplete ischemia, the pulse may be absent and may present in chronic ischemia due to collateralization. Perishing cold, unreliable, and paresthesia and paralysis, important feature of impending irreversible ischemia. This is most frequently caused by acute thrombotic occlusion. يعني ما دام acute فمعناها اكو sudden thrombotic occlusion of a pre-existing stenotic arterial segment. Thromboembolism and trauma may be iatrogenic as a causative agent. And there is a pain on squeezing the calf muscle. And when there is a pain, this is indicate muscle infarction and impending irreversible ischemia. The treatment of acute limb ischemia, if there is no contraindication, مثل انه aortic dissection او البيشنت عنده head trauma، فهنا يكون الانديكيشن for intravenous bolus dose of heparin 3000 up to 5000 units should be administered to limit propagation of thrombus and protect the collateral circulation. Acute limb ischemia due to thrombosis in situ can usually be treated medically with intravenous heparin. نعطي انتي بليتليت سواء اسبرين او كلوبيدوغريل، ونعطي المريض هاي دوز ستاتين and adding intravenous fluid to avoid dehydration. ونشوف المريض إذا عنده أنيميا نسوي له correction and adding oxygen if need, and sometimes the patient may get benefit from prostaglandins. Embolism will normally result in extensive tissue necrosis within 6 hours unless the limb is revascularized. يعني من يصير embolization لازم نستعجل بالrevascularization وإلا يؤدي إلى necrosis and gangrene and may ending in amputation. The indication of thrombolysis here still controversial لحد الآن ما صار اتفاق على هاي النقطة. موضوع جديد هو renal vascular disease. Disease which affect renal blood vessels and may cause renal ischemia leading to acute or chronic kidney disease or causing secondary hypertension ending in end-stage renal disease. First of all, the renal vascular disease is renal artery stenosis. Renal artery stenosis is a relatively uncommon disorder which presents clinically with hypertension and occur in about 10% of unselected patients with hypertension, but may affect 4% of older patients with hypertension who have evidence اللي عندهم atherosclerotic disease. Most cases of renal artery stenosis caused by atherosclerosis. وهنا الاتherosclerosis يكون بالrenal artery in a proximal part to its origin from the aorta, especially in elderly patients. But fibromuscular dysplasia as a causative agent for renal artery stenosis واللي يصير لنا in younger patient تكون دائما بالdistal part of renal artery. Other rare causes for renal artery stenosis include vasculitis, thromboembolism, and aneurysm of renal artery. The pathophysiology of renal artery stenosis. Renal artery stenosis result in reduction of renal perfusion pressure. راح يقلل لنا renal perfusion pressure وهذا يؤدينا إلى activation of renin angiotensin aldosterone system وبالتالي يؤدي إلى increase the level of angiotensin 2 وهذا احنا قايلين عليه في أول محاضرة هو vasoconstrictor agent. Vasoconstriction with increased aldosterone production by adrenal, both of them will causing sodium retention and hence will increase the blood pressure and causing hypertension. So significant reduction of renal blood flow occurs when there is greater than 70% narrowing of the artery وهاي الملاحظة ذاكريها في محاضرات سابقة. Atherosclerosis renal artery stenosis is the most common pathological cause and the characteristic lesion is an ostial stenosis of renal artery or proximal part مثل ما قلنا and affect other branch particularly the iliac vessels. هذا regarding الأثيروسكليروسيس اللي يصير بالألدرلي. Fibromuscular dysplasia اللي يصير بالyoung patient, it is uncommon disorder of unknown cause and it is characterized by hypertrophy of tunica media and it's most commonly present with hypertension in patient aging from 15 to 30 years and women are affected more frequently than men. وهنا الشكل مالت الرينال ارتري يكون بيدد مثل السبحه من نسوي له انجيوغرافي ودائما distally affected بالفايبروماسكولار dysplasia. Rarely renal artery stenosis occurs as a complication of large vessels vasculitis مثل tachyosis arteritis or polyarteritis nodosa. If the progression is gradual, there is collateral vessels may develop and some kidney function may preserve. ممكن تحافظ لنا الكدني على شغلها و prevent infarction and loss of the kidney structure. About 85% of patients with renal artery stenosis will not develop progressive renal impairment, and the stenosis may be insignificant and not responsible for coexisting essential hypertension. يعني هواي ناس عندهم renal artery stenosis وعندها hypertension، وحتى من نصلح للrenal artery stenosis يبقى ال coexisting essential hypertension. واحنا مثل ما نعرف hypertension 95% essential، 5% secondary، 95% من السكندري هو renal causes، and the most common renal cause of secondary cause is renal artery stenosis of hypertension. Clinical feature of renal artery stenosis can present the patient with severe hypertension, renal failure, with bilateral disease. If patient has bilateral renal artery stenosis and there is deterioration and reduction of renal function with elevation of blood urea ترتفع serum creatinine. إذا البيشنت عنده renal artery stenosis واستعمل AC inhibitor or ARBs and may cause pulmonary, acute pulmonary edema or flash pulmonary edema if the patient has renal artery stenosis and use such drugs. Although many patients experience a slight drop، ممكن يقل عندهم GFR slightly من يبدي يتعالج بالAC inhibitor كذلك والARBs، and creatinine increase by 25% or more. When this percent present, this give a clue for presence of renal artery stenosis. Acute pulmonary edema is particularly characteristic of bilateral renovascular disease. يعني المريض عنده bilateral artery stenosis وما ندري فيه، وتجي تفحصه تلقي acute pulmonary edema with unexplained cause، تروح تشيك Doppler study for both kidney، ممكن تلقي عنده renal artery stenosis but bilaterally. Clinical evidence of peripheral arterial disease may observe particularly in the leg in older patient with atherosclerotic renal artery stenosis. يعني اكو association between renal artery stenosis إذا موجود فنشك إنه المريض ممكن عنده clinical evidence of peripheral arterial disease. شو الانفستيجيشن اللي نسويها البيشنت with renal artery stenosis؟ المريض ممكن يحتاج CT angiography و MR angiography magnetic resonance angiography for renal artery, and there is a need for biochemical testing and assess renal function by serum creatinine, blood urea, renal level, and serum potassium with aldosterone level. Ultrasound may also reveal discrepancy in size between the two kidneys. من هم البيشنت اللي نشك عندهم renal artery stenosis؟ patient with high likelihood of renal artery stenosis first، أولا إذا عندهم hypertension، دول المرضى اللي عندهم hypertension وعمرهم أقل أو يساوي 30 سنة، أو عندهم hypertension بدأ أكثر أو يساوي 55 سنة العمر، اللي عندهم malignant or accelerated or resistant hypertension. المalignant هو high blood pressure فوق ال 200-220 with end organ damage. accelerated هو high blood pressure فوق ال 200-220 with no end organ damage. or resistant hypertension uncontrolled hypertension. 3. unexplained renal dysfunction. عند renal dysfunction يوريا كرياتين عاليات وما نعرف ليش فنشك بيه. 4. development of azotemia، تصعد يوريا وكرياتينين من يستخدم المريض AC inhibitor or ARBs. 5. من نسوي له سونار نلقي عدم تساوي بين حجم الكليتين، اكو ديسكريبنس اختلاف اكثر من 1.5 cm. 6. multivessels coronary artery disease، هم نشك انه المريض عنده renal artery stenosis. 7. peripheral arterial disease. 8. إذا المريض صار عنده unexplained flash pulmonary edema rapid deterioration with acute onset of pulmonary edema with unexplained cause فنشك إنه المريض عنده renal artery stenosis. Unexplained congestive heart failure or refractory angina pectoris. كلهم ذول ينطوني إيحاء إنه المريض احتمال عنده renal artery stenosis. يمتى نسوي للمريض revascularization؟ يعني نفتح الرينال artery stenosis هذا الليجن نتخلص من عنده either by stenting or by balloon. المريض إذا عنده accelerated hypertension, resistance hypertension, malignant hypertension, or hypertension with unilateral small kidney, hypertension with intolerance to medication. 2 renal insufficiency, and 3 recurrent congestive heart failure, flash pulmonary edema, refractory heart failure, or refractory angina pectoris. High indication for treatment with revascularization. هذا approach to the patient with renal artery stenosis كلش ضروري نفتهمه وهو كلش سهل وحلو. يعني المريض إذا نجي نشيك عنده clinical history و physical examination suggestion of renal artery stenosis. طبعا الphysical examination إنه بروي over the renal artery. فإذا ما عنده there is no need for screening for renal artery stenosis. إذا عنده هنا نسوي screening نستعمل ultrasound, CT, MRI and contrast angiography with precaution. فإذا no significant renal artery stenosis there is no further test. إذا significant renal artery stenosis أكثر من 50% صار stenosis فهنا ننتبه. إذا blood pressure well controlled وما عنده renal impairment نروح على medical treatment lipid lowering agent preventive other preventive measure. إذا لقينا size less than 7 cm with no evidence of renal function impairment with no evidence of renal function in the affected kidney فهنا revascularization not indicated. يعني السايز مقبول والفانكشن زينة. إذا لقينا عنده النقطة الثالثة indication of revascularization موجودة اللي احنا قرأناها قبل شوية. هنا نسوي له perform hemodynamic assessment by angiography. طريقة معينة بالانجيوغرافي. إذا لقينا pressure gradient across the stenosis أقل من 20 ملم mercury or the mean gradient أقل من 10 ملم mercury فهنا ما يستفاد من الريفاسكولاريزيشن معناها unlikely to improve الأوتكم. لكن إذا لقينا أكثر pressure gradient أكثر من 20 ملم mercury or mean pressure gradient أكثر من 10 ملم mercury فهنا أنا proceed with revascularization. Management of patient with renal artery stenosis. In elderly with renal artery stenosis, medical therapy with antihypertensive طبعا, statin, low dose aspirin in those with atherosclerotic disease. Angioplasty and stenting may successful in atherosclerotic patient, and the risk of angioplasty and stenting include ممكن يصير بعد الستنتينج on angioplasty ممكن يصير renal artery occlusion, infarction and atheroembolization. In young patient with renal artery stenosis, intervention to correct the vessels narrowing should be considered in the presence of indication. لازم عند المريض indication. وهنا التريتمنت indication for revascularization. وهنا التريتمنت of renal artery stenosis in patient with fibromuscular dysplasia or young patient is by balloon deployment. يعني هنا نستخدم بالون for angioplasty بدون stent with good renal outcome. موضوع آخر بالرينوفاسكولار disease هو acute renal infarction. This is an uncommon condition that occurs as a result of sudden occlusion of renal artery. The presentation is typically with loin pain of acute onset and usually in association with hematuria, but pain may be absent. يصير عندهم severe hypertension but not universal مو دائما. Blood level of LDH يصعد لنا والسيرياكتيف بروتين كذلك يصعد لنا. The condition may be caused by local atherosclerosis or atheroembolization. معناها اكو بليك بالايورتا فيصير بها embolization للرينال artery, or by thromboembolization from distant source. مثلا البيشنت عنده AF وتجي thrombus as emboli and causing occlusion, and this may occur in branch arteries distal to the main renal artery. If occlusion of main renal artery is bilateral, or if there is occlusion of single function kidney, the presentation is with acute kidney injury, and the patient is typically يصير anuric, تصعد اليوريا والكرياتينين, and there is no urine output. Patient with bilateral occlusion usually have evidence of widespread vascular disease. معناه ما دام bilateral occlusion معناه عنده severe vascular disease and may show evidence of aortic occlusion or aortic lesion with absent femoral pulses and reduced lower limb perfusion. The management is largely supportive and include anticoagulation if there is cause of thromboembolization. Sometimes possible to stent of an acutely blocked main renal artery to try to restore renal blood flow and kidney function. بعض الأحيان ممكن نلحق عليه if you present acutely. Other subject is disease of the aorta. وعندنا هنا aortic aneurysm, aortic dissection involving in this lecture. Aortic aneurysm تعريفه هو abnormal dilatation of the aortic lumen. A true aneurysm involve all layer. عندنا false aneurysm وعندنا true aneurysm. True aneurysm الدايليتيشن يشمل لنا كل اللاير مالت الايورتيك وول اللي هي تنكا انتما وتنكا ميديا وتنكا ادفانتيشيا. في حين الفولز aneurysm or الفولز aneurysm or pseudo aneurysm formed by leakage of blood from the all layer ويتجمع لي beside the aorta and pressed by surrounding tissue were forming collection beside the aorta forming false aneurysm. الانيوريزم طبعا ممكن يكون ساكولار from the side وممكن fusiform يكون total surrounding the aortic wall. Aortic aneurysm, there is many etiological factors and types of aneurysm. وهاي أمثلة على الأيورتيك aneurysm مثلا abdominal aortic aneurysm وعندك هذا proximal aortic aneurysm causing aortic regurgitation with dilated thoracic aorta بالمارفانز. وهنا عندنا saccular thoracic aortic aneurysm اللي يصير بسبب Atherosclerosis and syphilis. Etiology and types of aneurysm. Non-specific aneurysm may occur in association with occlusive disease. Aneurysm disease tend to run in family. The most common site for non-specific aneurysm when يصير عندهم بالinfra-renal abdominal aorta and the supra-renal abdominal aorta and variable length of the descending thoracic aorta may be affected in 10 up to 20% of patients. Ascending aorta is usually spared. Ascending aorta ما مشغول بالnon-specific causes of aneurysm. Second, Marfan syndrome. Marfan syndrome هو connective tissue disorder with autosomal dominant trait and is caused by mutation in the fibrillin gene on chromosome number 15. Affected system include skeleton يصير عندهم arachnodactyly, joint hypermobility, scoliosis, chest deformity and high arched palate. ويصير عندهم dislocation of the lens and aortic disease including aortic regurgitation and MR. يصير عند Marfan syndrome weakening of the aortic tunica media lead to the aortic root dilatation, aortic regurgitation and dissection. البريجنانسي هنا عند البيشنت with Marfan syndrome is particularly hazardous. Chest X-ray, echo, MRI, CT may detect aortic dilatation at early stage, and the treatment with beta blocker will reduce the rate of aortic dilatation and the risk of rupture. 3. Aortitis. Syphilis is rare cause of aortitis that produce saccular aneurysm، يعني من الجانب يصير عنده dilatation of aorta، وخاصة of ascending aorta والصورة روانكم إياها، and containing spot of calcification. Other rare condition associated with aortitis including tachyosis disease, Reiter syndrome, giant cell arteritis, and ankylosing spondylitis. 4. Thoracic aortic aneurysm. These may produce chest pain, aortic regurgitation, compression symptoms، ويسوي لنا استراديال إذا ضغطنا على التريكا والبرونكاس. إذا ضغطنا على الريكنت لارنجيال نيرف يسوي لنا hoarseness of voice. إذا ضغطنا على السوبريور فينا كافا يسوي لنا superior vena cava syndrome. And if aneurysm erode into adjacent structure ممكن يسوي لنا aortoesophageal fistula and massive bleeding. 5. Abdominal aortic aneurysm are present in 5% of men aging over 60 years, and 80% are confined to the infrarenal segment. دائما نشوف الانفراrenal segment mostly affected من aortic aneurysm. Men are affected 3 times more than women. The usual age of presentation is 65 up to 75 in elective cases, and 75 up to 85 for emergency cases. Ultrasound is the best way for diagnosis and following the asymptomatic patient. CT provide more accurate information. Management of aortic aneurysm. All symptomatic abdominal aortic aneurysm should be considered for repair. Distal embolization is a strong indication for repair regardless the size. ما عندنا إشكال بالسايز، ما دام عنده صار distal embolization فلازم نصلح. Most patients with rupture abdominal aortic aneurysm not survive and mostly not reach to the hospital. But if reach to the hospital, the surgery is mandatory. Open aortic aneurysm, abdominal aortic aneurysm repair has been treatment of choice in both the elective and emergency setting. دائما يكون surgical intervention by using Dacron graft. Special stent graft نستعملها حتى to repair aortic aneurysm. Endovascular aneurysm repair using stent graft introduced طبعا via femoral artery, and it is cost effective غالية and likely to be the treatment of choice، وخاصة نستعملها for EVAR، نستعملها treatment of choice for patient with infrarenal abdominal aortic aneurysm. Common presentation of patient with aortic aneurysm قد نحصله incidentally on physical examination or plain X-ray or abdominal ultrasound. زين، أو patient presented with pain in the central part of the abdomen, back pain, loin pain, iliac fossa pain, and groin pain. Thromboembolic complication ممكن يصير thrombus بالaneurysmal sac and embolization distally to the lower limb. Compression ممكن يصير compression and obstruction to the surrounding structure، مثل يصير pressure على اليودينم causing duodenal obstruction causing vomiting or pressure على الانفيرير فينا كافا ويصير عند المريض DVT deep venous thrombosis. Rupture into the retroperitoneal and peritoneal cavity causing swelling of the abdominal cavity. موضوع آخر هو الأيورتيك dissection. قلنا الأيورتيك أنيوريزم هو dilatation of the كل اللاير، وبنوعين false aneurysm وب true aneurysm. Aortic dissection could breach or tear in the integrity or in the layer of aortic wall, allows arterial blood to enter the media, which is then split into two layers. فيشكل لنا هنا false lumen and true lumen. The aortic valve may be damaged and the branch of the aorta may be compromised. Typically the false lumen eventually re-enter, ممكن يدخل لنا مرة ثانية الفولز lumen للtrue lumen, creating double parallel aorta كأنما يصير two tube. The primary event is often spontaneous or iatrogenic tear in the intima of the aorta, or there is multiple tear or entry points are common. The stage of aortic dissection هو stage 1 يصير rupture of the intima or tear بالانتما. stage 2 يصير dissection بالتنكة media, وstage 3 يصير rupture بالvessels والtear reaching the tunica adventitia. Aortic dissection we have two types. Type A, B subtype. First subtype of type A is aortic regurgitation involved with aortic dissection when involving ascending of aorta. Second subtype of type A, there is aortic dissection involving ascending aorta, arch of aorta and descending aorta. فالtype A هو there is involvement of ascending of aorta. Type B, there is no involvement of ascending of aorta, just involving the descending aorta. Other dissections are triggered by primary hemorrhage in the media of the aorta, which is then ruptured through the intima into the true lumen. This form spontaneous bleeding from vasa vasorum اللي يتغذي لي الايورتيك wall, and may present as painful intramural hematoma, يعني يصير hematoma بالwall of the aorta. Aortic disease and hypertension are the most important cause for aortic dissection. Chronic dissection may lead to aneurysmal dilatation of the aorta, and thoracic aneurysm may be complicated by dissection. The peak incidence is in the 6th and 7th decade, يعني بالخمسينات والستينات. But dissection can occur in younger age group, usually in association with marfan, pregnancy, trauma. Men are twice frequently than women. Aortic dissection is classified قلنا طبقا ل involvement of the ascending of the aorta. Type A dissection more common and account for 2/3 of cases. Many factors attributed as a predisposing factor to aortic dissection. تشمل لنا الهايبرتنشن 80%, aortic atherosclerosis, non-specific aneurysm, coarctation of aorta, collagen disorder, Marfan syndrome, Ehlers-Danlos syndrome, fibromuscular dysplasia, previous aortic surgery, CABG or aortic valve replacement, pregnancy وخاصة بالثird trimester, trauma or iatrogenic causes including cardiac catheterization or intra-aortic balloon pump. Clinical feature of aortic dissection, involvement of ascending aorta typically give rise to anterior chest pain يصير عندهم and involvement of descending aorta يصير عندهم pain to intrascapular pain. The pain is typically described as tearing, يصير tearing, severe and very abrupt in onset, and the collapse shock is common in the patient. Unless there is major hemorrhage, the patient is mostly hypertensive. There may be asymmetry, يصير عندهم asymmetry بين البراchial artery والcarotid والfemoral pulses, and there is a sign of aortic regurgitation, يعني المريض ما عنده سابقا هنا يصير عنده sudden onset of aortic regurgitation. Occlusion of aortic branch may be caused. مثلا إذا نسد الكوروني راح يصير عنده MI، وإذا كاروتيد راح يصير ستروك، إذا صار عنده spinal artery انضرب راح يصير paraplegia or mesenteric infarction with acute abdomen إذا انضرب عنده celiac or superior mesenteric artery. renal failure إذا renal artery involved, and acute limb ischemia if dissection extending lower down. Investigation for aortic dissection, chest x-ray show broad of upper mediastinum with distortion of aortic knuckle, but these findings are variable and absent in 10% of the cases. ممكن يصير عندهم left sided pleural effusion, والاي سي جي ممكن يعطيني LVH, or in patient with history of hypertension, or يعطيني ECG sign as ST elevation in the inferior lead, ST elevation in lead 2 و3 والAVF. Doppler echo may show aortic regurgitation, dilatation of aortic root, and occasionally there is a flap of the dissection. Transesophageal echo is very important and better than transthoracic echocardiography. CT and MRI angiography are highly specific and sensitive for aortic dissection. Management of aortic dissection, early mortality of acute dissection approximately 1 to 5% per hour. Initial management comprises pain control lazim, antihypertensive. Type A dissection require emergency surgery to replace the ascending aorta. Type B aneurysm are treated medically unless there is actual or impending, extending, or vital organ, gut or kidney or limb ischemia. The aim of medical management is to maintain mean arterial blood pressure about 60 to 75 millimeter mercury. First line therapy is with beta blocker and alpha blocker can be added مثل اللابيتولول اللي يحتيهم على اثنينهم ببيتا blocking and alpha blocking activity. Rate limiting calcium channel block مثل الفيراباميل دلتيازيم if beta blocker contraindicated. Sodium nitroprusside to control blood pressure, and percutaneous or minimal access endoluminal repair is sometimes possible and involve either يصير perforation or penetration للانتمال flap، يعني يثقبون الفلاب اللي صار so that the blood can return from false lumen to true lumen, or implantation of graft stent. And thank you.